Nancy for the conference. She's been our mainstay. She is our president, and we all love her. So, without wishing to embarrass her any more at all, I'd just like to say welcome, Sally. Thank you. I know it's been a supreme effort for you to be here, and it's great to have you. And this is just a little way of saying welcome back.
I'd just like to add to that, Sally, it's lovely to have you with us. I know you've been through a hell of a lot in the last few weeks, and to come here is fantastic. So,
It's been silly, but I've shown you
right, we're going to move on. We've got 4 more sessions, and it's entirely up to you. We can stay here till midnight if you'd like us to, but we'll build in some time for questions. We're now extremely pleased to have another visitor from the United States, Daniel Becker, Dr. Daniel Becker, who is, I'm led to believe, although it's quite dangerous, because I made some comments about Charles French Constant, and then he said, well, actually, I've been promoted. I was going to say he's an assistant professor of neurology at Johns Hopkins, but he might have been promoted in the intervening period of time. But he carries out, as one might expect, he's got a major focus of research into inflammatory spinal cord disorders, and is, in fact, concentrating, so I'm led to believe, on the use of embryonic stem cells in spinal cord repair. And he is going to talk to us about TM and activity-based therapy. Daniel, over to you.
Well, first of all, I want to thank you for inviting me. Thank you to the TM Society. It's a beautiful city. And I think you put a really nice conference together. Am I right?
Yes.
All right. So I'm going to move a little bit away from stem cell transplantation approaches. I think Charles and Doug have been giving some really nice talks. And I have been torn about how I'm going to start this presentation. First, you here? Because I'm trying to be as diplomatic as possible. So I decided, if I were in the United States, I would tell and I would give this talk, I would say one of the most important things that you have to consider when you're looking for a physician who takes care of you after a bout of transverse myelitis. And here I heard people have trouble finding the right urologist, finding the right GI person. And, I always say, you should look at somebody who is specializing in spinal cord injury, because a lot of things that happens with transverse myelitis, and almost everything in the chronic stage, is identical to a spinal cord injury. So, I haven't gotten any outside calls yet. So, and let's go a little bit into it. For when we talk about activity-based therapies, which is a way that we have of enhancing our own body's ability to restore function. As Doc had pointed out, we have endogenous stem cells. But what happens after the injury itself? So I drew this little cartoon, and I hope maybe at the end of this talk I'm going to be a little bit better neuropathologists and maybe neuroradiologists. And I'm going to explain this to you a little bit. So you see on... Yep, I'll do it. I think it works, right? Yeah, that's live. So when you're looking at this cartoon, as Doug had pointed out this morning, had really nicely explained the neuroanatomy. You look at the blue wires; these are the axons that are going from the brain up and down. There's a neuron kind of depicted here, which has a wire, and the yellow, which is probably hard to see from the distance, are the oligodendrocytes. Right? The oligodendrocytes are the ones that reach out and myelinate these wires. And if you look at this very closely, you can see that. I can hold it like this. How about that?
There we go. Not the best. Technology.
All right.
Can everybody hear now?
Yes.
Thank you.
You can hear me in the back? Excellent. I had to ask this question. So, I mean, if you look at one of these oligodendrocytes, and it's a long word, they have one cell body, they have many arms, and they reach out and myelinate multiple axons. And if you really count this out, one oligodendrocyte can myelinate between 40 and 60 axons. So in the case of transverse myelitis, if you lose just one of them, you lose insulation to a large number of wires. So that's why you see a disproportionate loss of function if you look at, if you just use a few oligodendrocytes. But at the same time, if you can restore a couple of new oligodendrocytes in the process of therapy, you can get this exponentially, or this disproportionate return of function. So if you look, this would be a lesion that you see in transverse myelitis. You see there's a lot of inflammation going on initially. You see this down here. If you look at the area around the injury site, you see that there is a scar forming, which is depicted in green, and it looks kind of very dense. If you look at oligodendrocytes, they die not only at the site where the injury is, but also at the site far away from the injury. And I'm going to have another slide later. I'm going to show you how much the spinal cord is actually affected. If you look at the myelin, so the substance that the oligodendrocytes make in order to insulate the cells, and Becker had showed you earlier that really nice picture where you had the axon in the middle and the thick wiring around it, and you saw that this was all really nicely and dense packed. After an inflammatory event, as the cells move back in and they're trying to remyelinate, then sometimes they don't do this correctly. You see this loosely wrapped myelin, and so as long as when the myelin is wrapped that loosely, it's most likely not functional. And then the last thing you can see that even neurons, so if they're long enough, if the axon is long enough injured, so as it passes through here, at some point the neurons themselves are going to start to die. So it's a very long process. So if you look, now this is the next step, if you look at the whole spinal cord, we always think you do an injury to the spinal cord from either inflammation or trauma, and we always think that the injury is just at that one site and nothing else is affected. But if you look at that very closely, and this is this time in an animal, and I told you I'm going to make you neuropathologist, C2 stands for cervical 2. So this is a cut of a spinal cord from the cervical spine. The next one is T1, is thoracic 1, so you kind of in the upper part of your neck. And then you go to T7. The injury is placed between T7 and thoracic 11, which is kind of the lower part of your rib cage in the back. And then you have lumbar 1 and lumbar 5, which is the bottom of the spinal cord. Anything that is white on this picture are cells that are trying to eat up tissue that is dying. Okay, these are inflammatory cells that have moved into the spinal cord in response to an injury. If you look at that, this is 5 weeks after an injury, and this is in a rat. The rat recovers actually very nicely. So we know that an injury at any level of the spinal cord not only affects that one level, but levels all the way up and down of the cord. So that's why in terms of therapy, we have to focus on therapies that, physical therapy and occupational therapy, that focuses on multiple levels all across the spinal cord. So that going on very, very nicely this morning. So we know that there is spontaneous regeneration going on in the spinal cord. And so after Doug's cartoons, I thought I'm going to bring in some real-life pictures of some of these cells. And so you see the really star-formed cells with this big network. These are oligodendrocytes, look very nicely in a culture dish. These are the ones that do the myelin. Then we have astrocytes, and there are 2 different types. There's this type here and that type there. These are the ones that are more in a supportive role of the spinal cord. And then we have, of course, the neurons, the big wires, as they go up and down. So when we talk about regeneration, we're trying pretty much to replace just one of these cell types or all four of them. So which cells do we know are existing in our spinal cord? And you see on the left side, it's called a tripotential progenitor, which is kind of the stem cell of the spinal cord, which, if I take it out and I put it in a culture dish, it can make a neuron, an oligodendrocyte, or an astrocyte. So any of these cell types is possible. As they start differentiating, getting older a little bit, and start choosing a fate, in the spinal cord, we are losing the ability of making neurons. And these are called bipotential progenitors, or as Doug pointed out earlier, glial progenitors. So these are cells that can become astrocytes or oligodendrocytes. And then as they get older, you see on the right side there's an astrocyte out of the left spinal cord and an oligodendrocyte out of the left spinal cord. So these are the cells that we're trying to focus on. And we have looked very closely over many months in animals, and we've never actually been able to restore a neuron in the spinal cord. But we know that we're pretty effective in trying to build some of the, or to generate some of the astrocytes and oligodendrocytes. So we also know that these cells are born all the time. While we're sitting here, each and one of us makes thousands of those in our spinal cord. We used to think that we are born with a set of stem cells and we get old with them, or a set of neurons and we get old with them. So we thought the brain is one piece, and once we're 80 years old, every single cell in there is 80 years old because they don't turn over, and we used to think the same thing about the spinal cord. And then we've learned about in the last 10 plus years that these cells turn over all the time at a pretty rapid rate. And which kind of makes sense because this is a very active system. Signals have to go from the brain, travel down the spinal cord. The cells are under a pretty high amount of stress, so I think it makes a whole lot of sense that they turn over all the time. Very important one. So I'm going to get back to that. So then you might ask, where do these cells sit? So here we again have a spinal cord and the cross section of the spinal cord, and you see the whiter structure here, the little butterfly structure. This is the gray matter, and the dark stuff here is kind of opposite, is the white matter in the spinal cord. And you see that these cells are born. So if we do a high power image, this is how they look like. So all these little white dots. And if you look from the distance, where are they? So you see they're born pretty much all throughout the spinal cord. Most of them actually in the white matter tracts. So here on the outside, here and there, but also some in the gray matter. So the cord itself not only births cells in certain spots, but it's pretty much throughout. As we pointed out and Doug pointed out earlier, we know that neurons are only born, to our knowledge right now, in the brain, not in the spinal cord. And we know that the neurons themselves have a pretty good capacity of regenerating some of their axons. So once those wires get cut or destroyed through an acute inflammation, there is some capacity of these neurons to grow back out that arm and try to make new connections. And but in many cases, these connections are not made appropriately. So sometimes we have, which is one of the bases why we think, for example, that neuropathic pain can be a problem. And so the spontaneous way of the spinal cord. So we know that regeneration takes place all the time, but spontaneously it's extremely limited in the spinal cord. And so what can we do to make it better? So the last concept I want to introduce before we go on is how much of the spinal cord do we think we need to repair? Most people, when I speak with them, always say, well, you want to replace the whole lesion, anything that is there. But that's generally not true. In animal models of spinal cord injury, you can show that you only need about 18 to 20% of your connections across the spinal cord to be able to walk. And we think that in humans, this is actually even less. We have a trial going on right now where we looked at patients with cervical spinal cord injuries, and we're doing very fancy MRI where we try to count the connections that are going through the cervical spinal cord in people who are walking. And so from there, we think we only need about 10 to 15% of our connections to walk. And so what's the reason for that? Most people don't know that we don't generally need the brain to walk. Anyone has grown up on a farm? No? You ever had a chicken?
Yes.
Well, we know they can run and they can fly until they run out of oxygen. That's generally the problem. But so the program for walking is in the spinal cord. There is a little tiny microcomputer in your lumbar spinal cord, which is called the central pattern generator, or CPG, which is kind of the program that encodes walking. And what do we need the brain for is the brain turns on that little generator and says, start walking, it turns it off, stop walking, and it modulates it, says go faster, go slower. That's all you need your brain for. Everything else is in the spinal cord. Because otherwise your brain would be terribly busy if you had to kind of think about every single step you take. Then if you try to run, it's even worse. So we don't need a whole lot of repair. So the concept of activity-based therapies is kind of based on everything I just said. Because we're trying to increase activity in the spinal cord below the level of injury. So, and I have a slide to that. If you look at this as the spinal cord and we kind of zoom out, the red would be the area of inflammation following the episode of TM. And now we're going to look at the spinal cord from the distance. So on the left side, this is the bottom of the spinal cord, which is called the cauda equina. And on the right side is the cervical spine. And here to your right, over there where Doug is, would be the brain. So, multiple centers of expression. So if there's the lesion, then we know that anything that's connected to the brain has pretty much normal activity because it can get the brain sends and signals all the way up and down this cord. So this part of the spinal cord is generally okay in terms of its activity and in terms of its cells as they turn over again. Below the lesion, where the input doesn't come in, you see there's a dramatic decrease in activity. It's kind of depicted in blue. And it has two reasons. Number one is the activity from above the injury can pass through, or only very limited. And the second thing is that for example, the traditional rehabilitation approach, which we have done for many years in the United States, where we said somebody with a spinal cord injury, don't worry about anything that goes on below your injury site because you don't need it anymore. All you have to do is take care of your arms. And you put this person pretty much in a wheelchair and say, okay, come back when you have the problem. So you deprive this part of the spinal cord not only from the input from above, but also the input from below. Because every time you move a muscle, you move a leg, or anything, you send signals into this part of the spinal cord. And what happens in this spinal cord is pretty dramatic. If we say the cell birth, kind of the region of the generation of stem cells and the replacement of cells that have been used up, what I kind of tried to point out earlier, the baseline cell turnover is, let's say it's 100% up here. It decreases by 50 or 60% in the lower part of the spinal cord. So we're trying to ask this system down here to repair when it actually has trouble maintaining its function. So what activity-based therapies is targeting on, what can we do to improve, to normalize activity in this part of the spinal cord? When we do that, we think we can restore some of the regenerative potential that the cord generally has. Does it make sense?
Yes.
You can interrupt me anytime. So that's one of my favorite graphs, and I think that's probably the most important one that you can take with you. There's going to be one very complicated at the end, but this one is my favorite. So if we look at, if we try to plot out on this axis activity and this axis regeneration. we think that if we can, the more activity we put into the spinal cord, the more regeneration we're going to get, right? Makes sense. And then one would think, like with any process, there's always an upper limit. You know, if I use too much activity, I'm going to reach that peak, and maybe at some point, too much activity is bad. That's a very common problem that people see. If we say that after an episode of TM, your activity is, you kind of plot on this curve somewhere down here. The way we're going to move up this curve would be?
More activity.
Correct. ABRT. So activity-based therapies. So, you know, we still have the question, so can we do too much ABRT? And we have looked into this very, very closely. And we have tried this in patients. We were not able to find the upper limit. Then we went into the animals, and we were not able to find that upper limit. And then we thought, well, maybe we can do it in a culture dish. We can put cells in, and we can stimulate them as hard as we can. And at some point, we find this upper limit. But even there, we have not been able to. So it doesn't mean that it doesn't exist, but we think that at least with physiological ways, it's impossible to do too much activity. Okay? And maybe in some patients with TM or ADEM, fatigue might be a limiting factor, but that generally works out after a while on getting ABRT. Questions? So what does an ABRT program look like? What do we use? So we use a technology which is called functional electrical stimulation. And there's a big point in the word functional, because whatever electrical stimulation you use, you want to combine it with the function. If you don't have the function attached to it, it's generally much less effective. And I spoke with one family during the break, which kind of asked, so do I just put an electrical stimulator on an arm and just let it go? And I said, well, it's probably not the right thing. We have to combine it. So if you want to do an arm, you want to do it with a grasp. For example, there are units out that I've seen here, the BioMS unit. You probably have seen outside. There are other external devices like the RT300 FES bike. I see you guys are very fortunate to get the RT600 FES walking system, which we have been unable to get approved by the FDA so far. So I think you're going to have studies with it much earlier than we will. There are smaller units out there, so it doesn't have to be a big, expensive 20,000-pound equipment. There are handheld neuromuscular electrical stimulator units. I know many of them, at least who I talked to working with them, that you have 1 or 2 channels and you can stimulate 1 or 2 muscles at a time. Ours are called MP, EMPI, and Intellect. There's FES bracing out there, so for people with foot drop, instead of using an ankle foot orthosis, in some people it would be very beneficial, it would be much smaller, to use an FES bracing system like BioMS has or Walk8 has. And then if you go back in the past, I mean, FES systems have been around since probably the 50s and 60s. And the other ones that we know is the cardiac pacemakers, we have cochlear implants. In spinal cord injury, we used to have a system, it's called the freehand system, which was an implantable FES system to kind of restore grasp. That's not being offered anymore, there were too many complications with it. There was a bladder emptying system, there was a pure FES system. And then diaphragmatic pacing is still very big. For people who need a ventilator, and you can actually get them off by an external pacer of the diaphragm. So we think, because I think Lou had asked me to make a good point out of this, that there is a lot of science what's actually happening if you do this. I mean, so far this was all theory. And now we're going to bring this a little bit forward and say what's actually happening when you do this FES. So number one, we know that we can cause synapse formation. So meaning the connection between 2 neurons, 2 nerve cells, or for example from the brain to the spinal cord, that it increases. We know that myelination, so insulation of the neurons, increases with that. We definitely know that there's cell growth. I'm going to show you some data on that. And we have some data that actually shows that the cells survive much better if they are active. We know that the activity is decreased below. I'm not going to go back to this one. And so, now the big question here in this audience, which I was surprised to hear, is what does an FES system actually look like? And we kind of discriminate between two types of activity with FES. One is called pattern activity, and one is non-pattern activity. So pattern activity kind of includes, for example, FES cycling, meaning devices like the RT300 you see outside, walking systems, and then the grasp devices like the BioNS. Partial weight-supported walking is a big part of that. There are several treadmill systems, and there are actually even robotic treadmill systems. You've probably seen from Hokoma, the Locomat, for example. Then you have assisted movements. For example, for people who are not strong enough to power a bike with FES, you can have motorized bikes. And they come from all kinds of different vendors. You can buy them in a local hardware store. And then there's passive movements that you can do with the physical therapist, for example. Non-pattern activities is kind of the old way, for example, of isometric strengthening with an FES device. If you go outside the rehabilitation field and you see where are FES devices used, you can see that people who do a lot of strength training, like powerlifting, they use FES devices. They push to the maximum what they can do, and right when they reach their limit, then they power up the FES and get the last couple inches out. We don't do it as intense in therapy. You have multiple biofeedback devices, and then the bottom one, aquatic therapy, is a big part of an ABRT program. So the big point on all of this is ABRT not just only means you go out and buy an FES bike. That's not what we're trying to do. ABRT is a combination of these approaches between electrostimulation, gait training, grasp training, aquatic therapy, biofeedback. You create an ABRT program, individualized for the patient. And then if you do so, you will show improved recovery. The FES bike, I don't know, who's familiar with the FES bike? Wow. All right, let me then explain it a little bit better, because I assume people are more familiar with it. So what this is, it's a bicycle, like your recumbent bike. But since most people can't power it on their own because of paralysis, the muscles of the legs are being hooked up to a computer. So you have electrodes sitting on your hamstring, on your quadriceps muscles, on your hamstrings, and on your glute muscles, on both legs. So then you sit on this bike, and a computer will start activating each muscle group in the right sequence. So it starts when you start with the electrostimulation, that muscle contracts. So for example, and it's done in a sequence that you induce a cycling. So one leg starts moving this way, the other one that way. So it kind of takes the function of your brain. So when you do that, you feed activity into your lower spinal cord, which activates that central pattern generator we talked earlier about, which then starts pretty much playing back that program for walking. And so these central pattern generators in your lower spinal cord, they talk to each other. There's another one up in the cervical cord, which is for grasp, and these things all communicate to the brain. So you not only activate at the level of the lower spinal cord, like you would think when you do the FES bike, but you also activate pretty much levels all the way up and down the spinal cord. And then the beauty of the FES bike is you can set the resistance to the cycle itself. You can almost treat it like a recumbent bike. And because even if you don't have enough control from your brain over your legs, the computer will take over and it will start firing the muscles so that the bike starts moving. If it encounters that you're too weak to actually move it forward, then the computer will first try to increase the stimulation, so it kind of does up the juice, so you get a better contraction, it brings forward. If at some point it realizes that, well, maybe even to the maximum level that you have set, you don't have enough strength to do so, then it will kick in its motor and starts moving you. And then it starts feeling out when your strength returns and you keep going. And so the program on the FES bike generally lasts about 60 minutes, and we generally do it 3 to 5 times a week at least. And so you give somebody who has absolutely no way of getting a good cardiovascular workout, except doing it with the arms, and you can actually do it on the bike. Even I have been sitting on this bike in the past. It stings a little bit because of the electrostimulation, but you get a really nice workout, and the computer will overpower you if you get too weak. It just does it instant. So what happens when we do that? So you stimulate a group of muscles. So the first logical response is that you increase muscle mass and with its strength. So when you do that, you have now from people that have that experience when they have TM and haven't used their legs a lot, they kind of start shrinking, the muscles get smaller, and you can't even feel them. They kind of get replaced by most of their fatty tissue. And so to build them back up, you get some padding underneath the skin. When you do that, and you put more stress on the bones, you will start helping the bones to regain some of their bone mass. So your risk of osteoporosis gets lower. And with the lower risk of osteoporosis, you have a higher probability of not breaking anything. We know that you get a very enhanced blood flow in your legs, and you get a nice cardiovascular workout, which I hadn't been able to do before. And then when we look at this in larger groups of patients, we can show that there's less fractures because you have less osteoporosis. Because you have more padding between the bone and your skin, there's less risk of skin breakdown. People form less blood clots. Spasticity is a big one. So if spasticity is a big problem for you, then getting onto a good FES cycling program can be very helpful. We looked at that in around 2001. In a large group of patients, about 120 patients that we followed for over a year. And we could show that in about 70% we got lower doses of spasticity medications. In about 20% we got the patients completely off of that. And the other 10% that were left, they had no changes. So the worst case is that nothing happens. But the most likely thing is that you will need less medication and probably have better spasticity. One point of caution is when you start an FES program and you have some spasticity, there's some people are very concerned initially because spasms kick in, they get more. And it's a very common phenomenon, and I think it's simply explained. If you, for example, have a spasm in a weak muscle, so this kind of would be like this. Once you build up that muscle, just the strength of the muscle, all of a sudden that same spasm looks much worse. So if you go on such a program, give it about 4 to 6 weeks, and you will see the decline of spasticity. The main reason why we do ADRT is we think we can enhance your body's own repair mechanisms. We think that enhance regeneration, and that's something that has initially got us in trouble with a lot of our peers. Because it used to be impossible, at least in many books it was written like that. And so we just published last year the data on that, and that's probably the most boring part I'm going to be doing. So since we can't look at spinal cords in our patients once we treat them, because they're not very willing to give up a piece of their spinal cord, we had to kind of take this whole model back to the animal. And so again, we used rats. They are very easy to work with when they have spinal cord injuries. And we did a very complete type of spinal cord injury, and then we gave them FES. So you might ask, how do you give a rat FES? Put them on a bike? And so this is the way we do this. There's in the top right corner, you see this little device. That's the stimulator that we pretty much implant under the rat's skin. There's a dime next to it. It's my first time in the UK, so I can tell you what the size difference would be to a British coin.
Probably about 5 pp's.
Okay.
Yeah,
So,
take a 5 pp's.
so it's small. And then this little computer has a chip in it. This little light dot is a sensor, light sensor. So we pretty much implant the system under the rat's skin, and then we wire the FES wires to their lower limbs. And the way we turn this thing on is with a light switch. So, anybody still familiar with an old timing light from a car? Okay. So it's like an old flashlight. So you can basically go to the cages and then you shine this flashlight onto the rats in a certain sequence of flashes, which turns this thing on or turns it off. So then you will have basically rats in cages who start moving their legs. And we have done this 5 days a week, 3 hours a day, which I think is kind of the minimum that we would like for people to do an ABRT program. And then look what's happening in their spinal cord. And so I'm not going to take you through this whole slide. The main point I'm trying to make here is that, again, the idea would be cervical 2, this would be lumbar 5. The injury was done T9, T10. So if you compare the blue and the yellow is the animal that has gotten FES, blue is the animal that didn't get FES. And you see that below the injury, if you just look at the blue, that the cell turnover itself gets down. That's what I pointed out earlier, right? Because the pure maintenance of the system is impaired. If you turn on the FES, you see that you get the levels back up. And so then we look back and see, so what are these cells? And we know that these are those glial cells that we talked about earlier. These are oligodendrocytes and astrocytes. And that's kind of the reason why we think ABRT is so effective in terms of regeneration. So we think, well, we know that so ABRT can restore levels close to normal below the level of injury. And by doing so, you get the primary benefits of ABRT, like a good cardiovascular workout, improved bone mass, less infections, less skin breakdown, and spasticity.